In our series of lectures on medical negligence issues and learning from them, today I have picked up a case in which the hospital, the treating facility, could bring out before the Honorable Supreme Court, as well as while facing NCDRC preliminary, their case in a very effective way. The whole aim of this lecture of today is to see that how a legal liability arises, how the doctors become liable for their duties, as well as how a good record keeping and good medical practice can pave the way for a favorable outcome in a lawsuit like this. So without much ado, let us begin. We will cover our discussion today under the following heads. So before, as usual, I generally introduce the parties to the suit first. Here, for our easy understanding, the patient side was the complainant before a National Commission, in which National Commission did not agree to their lawsuit, dismissed the petition for a compensation of 45 lakhs. And therefore, complainants in that became appellants. That means the patient side are the appellants in Supreme Court. And the treating hospital, that is the Batra hospital, and the doctors there too, were the respondents. The fact of the case stands as Shri R.K. Sharma was in his early 50s and was a very well-known senior operational officer in Indian Oil Corporation, who developed breathlessness. He was very obese and also hypertension. He started having difficulties in climbing stairs. And with these complaints, Mr. Sharma visited Mulchand Hospital. However, the cause for his breathlessness and swelling was could not be detected in Mulchand. And subsequently, his employers, that is IOC, referred him to Batra Hospital. And he visited Batra Hospital on 14 March 1990. There, he was seen by Dr. R.K. Mani, who diagnosed this case as a case of anasarca. And subsequently, on 18th March, he ordered certain investigations, including ultrasound abdomen and CT scan abdomen. Also, at the same time, the patient was worked up for bone scan as well as CT scan brain. With all investigations, it was thought and found that he is having a suprarenal gland tumor, which is thought to be a malignant tumor, and he was advised surgery for the same. Initially, a thought process was given that whether mitotane can be given to him. However, he did not tolerate the toxicity, and therefore a surgery in favor of removal of the adrenal left suprarenal gland was taken. And surgery was carried out on 2nd April 1990 by one Dr. Kapil Kumar. During the process of surgery, the patient was told that surgery has been successful. However, one tube was found attached coming out from the left side, left anterior portion of the abdomen, from which blood and some secretions were dripping, and some bag was found fitted. On query of the same, it was stated that these secretions are normal, which will reduce on its own in few days' time, and the patient will be all right. However, the secretions and the bleeding and discomfort, pain, anxiety, everything continued. Meanwhile, as the tumor was found to be, during operation, was found to be a secreting tumor, the slides and the mass was preserved, and the slides were examined in the Batra hospital itself. On examination histologically, the slides were found to be indicative of adrenocortical malignancy. And as I said, as the fluid and the blood and other secretions were not getting stopped from coming out, and the patient was in huge discomfort, the matter was referred to one Dr. T.K. Bose, who was a GI surgeon and consultant surgeon in Modi Hospital. It was decided, after 45 days of this surgery, it was decided on 17th May 1990 that the patient would be undergoing ERCP, that is endoscopic retrograde pancreatocholangiography. That was done. And thereafter, another surgery was planned. At that time, on specific query, it was told to the patient that the pancreas was all right to begin with. However, during removal of the adrenal neoplasm, the pancreas got injured, which was repaired, and therefore there probably some collection and pus. Again, on deep probing, the doctors revealed to the patient that during the process of surgery, a spleen was removed. At a later stage, when the matter came up before learned NCDRC and also in Supreme Court, this was vehemently contested and relied upon by the complainant as well as that is the patient side in NCDRC as well as in Supreme Court. And Dr. Bose did the operation, and he had fitted two large tubes draining the pus and other collections in the lower and anterior and lateral wall of the abdomen. A fitting jejunostomy was planned, which was not successful. The pus started draining out. Two bags were fitted in the abdomen. And it was stated before the patient that the operation, the surgery has been successful. As the fluid draining would get reduced, the wounds were supposed to get healed inside, and the patient was expected to be all right in due course of time. However, that did not really happen the way it was planned. The patient was advised frequent visit to the hospital after he got discharged, which he didn't do. Finding him not attending the hospital, Dr. Mani and Dr. Kapil of Batra Hospital visited him at his residence. Meanwhile, the patient had written to IOC stating that he was extremely mishandled and has to go through a lot of pain and rigor because of the dealings that is done by the Batra Hospital. Also, within the same course of time, he visited Dr. Bose in his clinic at Modi's hospital, where the dressings were done and he was told to report back again within few days for change of dressing, which he didn't do. On request of Dr. Mani and Dr. Kapil, the deceased visited AIIMS and he was diagnosed to be having chronic pancreatic as well as fecal fistula, and same was dressed at AIIMS. Thereafter, he again got admitted in Mulchand Hospital. Dressings were done, and while returning back from Mulchand Hospital to his residence on 31st August, the patient visited Batra's hospital. And that is not for any consultation, but he asked for a fitness certificate, which was given to him by Dr. Mani. And even at that time, it was advised in writing to the patient to report back within 2 or 3 days for change of dressing and further follow-up. However, the patient did not do so. He thereafter went to Jodhpur and got admitted at Mahatma Gandhi Hospital, where he was diagnosed from suffering from post-operative complication of adrenectomy as well as gluteal abscess. The gluteal abscess was drained by crisscross incision, and a gravitated drainage was planned, and he was discharged on 8th October 1990 for further treatment at AIIMS. The patient reported in AIIMS and he was called back after a few days for a case presentation. However, on 9th October 1990, Mr. Sharma had episodes of hematemesis, and on information to the Batra hospital. The hospital provided him ambulance and he was admitted in the Batra hospital. Unfortunately, the patient breathes his last on 11th October 1990 on account of pyogenic meningitis. Aggrieved by the entire turn of event, wherein patient claimed deficiency of service and negligence on the part of treating doctors and stated that it is a cumulative act of negligence by repeated omission and commission by the doctors that the patient finally had to lose his life, and a compensation claim of rupees 45 lakhs was made against the hospital and the doctors. Learned NCDRC dismissed the complaint on the ground that the complainants, that is the patient side, completely failed to prove any actionable negligence against the hospital and the doctors. Aggrieved by the same, the complainants preferred the subject appeal before the Supreme Court. Now, what are the perspective of appellants, that is the patient side, when they came before the Supreme Court? The basic challenge was that the patient side, that is the complainants or appellants, were not informed in time about the damage to the pancreas as well as removal of spleen. The tumor that was removed, that is the tumor of the left adrenal gland, was not malignant. Actually, there had been a collusion. This is what was alleged between Batra hospital and another hospital. And the reports were fudged. Third point of contention of the appellants were that the malignancy reported by Sri Gangaram Hospital was in collusion, as I stated. The main contention here was the anterior approach adapted for surgery of the adrenal neoplasm was not the right approach. Also, doctors who were not part of the hospital, that is Dr. T.K. Bose, as well as one Dr. Nandi, who was HOD gastroenterology NIMS, were also made parties to the suit. And also it was challenged that the advice of Dr. Nandi was not followed by Dr. Bose when he did the second surgery. That the gluteal abscesses diagnosed at Jodhpur was because of continued septicemia in the body, which resulted finally into pyogenic meningitis. And respondents have been out and out careless. As a result, the patient had to suffer the maximum, to bear the price of this negligence through his life, and a compensation claim of 45 lakhs was raised before NCDRC. The perspective of respondents were quite varied. While giving reply point by point rebuttal, the respondents, that is the hospital and the doctors, first stated their condolences for a sad demise of the patient, but vehemently denied that any material fact was ever hidden from the patient. It was stated that it is never told to the patient that the operation was successful. Only thing that was told to the patient was that there had been no spillage and that neoplasm was removed in toto, completely. It was never stated to the patient that such flow of fluids and blood are normal and it would heal naturally. The responding hospital and the doctors relied upon operational transcript, that is operation notes, and discharge slip, stating that these are all mentioned in the discharge slip and operation notes. However, to the claim of the patient during argument that this discharge slip as well as the operation note was never made available to her. The deceased wife was the appellant, so it was never given to her. The doctors, though, relied upon that these were already on record, but they really could not state as to on which date that these informations, these medical records were provided to the patients. So therefore, the claim that the patients were not aware about removal of spleen as well as damage to the pancreas was accepted by NCDRC. It was sustained. The next point, please, at this point in time, I would like to state one thing. And repeatedly, I am saying NCDRC because the entire argument took place before NCDRC. You must understand that during an epi, the correctness of judgment, the procedural aspects are looked into by Supreme Court and not the facts. Facts are not reappreciated unless new facts have been brought up before the Supreme Court, which was not initially alleged. Anyway, coming back to the case, that the respondents also stated that just because a predicament has followed, it does not imply that the clinic or the specialist has been blameworthy or careless. It was stated that both Dr. Kapil Kumar as well as Dr. T.K. Bose were very renowned and experienced surgeons. The surgeries performed by them were successful. However, the outcome of the process was not as expected. So far as whether the tumor mass was malignant or not, it was stated that the tumor mass was sent to third-party hospital. In Batra Hospital, it was diagnosed as a malignant tumor of the adrenal cortex. Similar report was found in which even the Mulchand Hospital, what the appellants relied upon, that Mulchand Hospital did not return the report. It was stated that Mulchand Hospital indeed has stated that there are stray mitosis and infarcts, there are hemorrhages in the slides. At this point in time, the appellants rebutted this claim by stating that Tata Hospital stated that the slides were extremely badly made. It's a very unprofessional job that was done by Batra Hospital. The slides were so bad that they could not reach to a diagnosis, and no tumor mass were provided to them so that they can check the veracity of the report. To this, Batra Hospital stated that as per hospital policy, they retained the tumor mass only for 1 month, which was accepted by NCDRC, as they said the tumor mass cannot be retained lifelong. So therefore, since 2 hospitals and the other 3 hospitals agreed to the general finding of neoplastic changes in the tumor, the report was said to be correct, and the claim of the appellants that the lab report was colluded and fudged was not sustained. It was also stated by the hospital that the hazards of surgery were disclosed to the patients and the family of the patients, and also the risks. Also, it was stated that the surgery was the only way, as the patient is not tolerating oral feed and is not tolerating mitotane. This was also disclosed, and this was taken in consultation with conference of the family doctor of the patient. Now coming to the main crux of the case, that is whether a correct approach and a correct surgery was performed by the respondents. To sustain or substantiate their claim, the appellates referred many literature. First thing that was referred to was one of the famous books of abdominal surgery known as Mangot's Abdominal Surgery, wherein it was stated that small tumors of adrenal cortex, which is resulting in hypercortisolemia, can only be treated by removal of the gland. However, this book says that such hypersecretion are generally taken from adrenal adenomas and not from adrenal carcinomas. The patient relied upon this, stating that this is the reason that that operation was preferred by the doctors, because it was actually an adenoma and not an adenocarcinoma. The second part, then the patients also relied upon a book called Complications in Surgery and Its Management, This book is authored by Curtis F. Arch. This book clearly states what would be the approach to an adrenal cortical tube. The book stated that the anatomical position of adrenal gland, especially the left adrenal gland, is such that if you approach it anteriorly, the sight and the vision is very, very restricted. It's very difficult to approach left adrenal gland through anterior incision, as the gland lies beneath spleen and above pancreas. So there is every chance of injuring the splenic artery and vein, which are big vessels, and also chances of injuring the pancreas is very high. The best approach as per this book is a posterior approach, in which an oblique incision is given on the psoas to approach the spleen, to approach the adrenal gland without confronting the great vessels and other structures. It gives a more or less an avascular space to operate upon. However, this book also stated that if there is a neoplastic change in the tumor and the tumor size is above 4 centimeters, I would like to take the listeners back to a fact that the tumor size was 4.5 centimeter by 5 centimeter in size as per USS abdomen, and also it weighed more than 50 grams. So the book said such a large tumor can preferably be taken out through anterior approach only, as it allows general inspection and you can see whether there are other seedlings or not. So therefore anterior approach was also can be done, though anterior approach had been told as a more difficult approach and risky approach. To counter this, the respondent produced many literature in which it is stated in a book called Peritoneum, Retroperitoneum and Mesentery, as well as technical aspects of adrenalectomy written by Clive S. Grant. It was stated that the only way of approaching an adrenocortical tumor, which is large, is through anterior approach. There are two ways that they said it could be done. It can be a midline incision, wherein en bloc medial shifting of spleen, pancreas, and splenic flexure of colon can be done through blunt dissections of mesenteries and avascular fields, and thereby this way the left adrenal gland can be exposed brilliantly. Otherwise, the dissection can be through lesser sac, and that is how it can be approached. That left adrenal gland can be approached. However, it is categorically stated that if a neoplasm is suspected and tumor mass is big, anterior approach is the only approach that is preferred. Also, many literatures stated that despite due care, injury to pancreas and spleen is not uncommon when approaching almost a retroperitoneal structure like adrenal. In fact, while deposing Dr. T.K. Bose while deposing Dr. Nandi also stated that even he would have preferred an anterior approach to operate on such tumors, and so was the expert surgeon, Dr. Shukla, who is an oncologist. Everybody stated that they all would have preferred an anterior approach and not a posterior approach. Then the matter came that Dr. T.K. Bose, while operating the second time, did not go as per the advice of Dr. Nandi. Dr. T.K. Bose defended this condition very aggressively and stated that the decision as to what to do in the operation table lies entirely on the treating surgeon and not to somebody else who have merely advised. He also stated that exactly as per the advice of Dr. Nandi, he has placed the tubes and the bags for collection of fluid. He stated that there had been a lot of adhesions occurred within a month's time because of the infection, and therefore the advice of Dr. Nandi of having a fitting jejunostomy was not possible. A fitting tube was tried to be inserted 4 times, which was not successful. Also at this point in time, the court noticed the actual contributory negligence on the part of the patient. It is known that if a nasojejunal tube could have been put, then pancreatic secretions would have been reduced. However, the patient did not allow this to be put. So therefore, there had been a contributory negligence also, the part of the patient, as noticed by both NCDRC as well as Supreme. Having gone through all these, the issues that came before the court, that whether the tumor removed by Dr. Kapil Kumar in the first surgery was malignant or not. As I stated very clearly, that various hospitals, wherever the slides and tumor mass were sent, were given almost concurrent or similar report, near similar reports. The Mulchand hospital also echoed, stating that there had been mitosis. Batra hospital clearly stated that there had been malignancy, and other hospital also stated that it appears to be that there has been an adrenocortical malignancy. The report that the appellants on the patient side, which they were relying heavily, that is the Tata hospital, no report of Tata hospital was put on record, nor any of the doctors of the Tata hospital was made party to the suit. So therefore, this claim did not sustain much water, did not hold much water before the Supreme. Now, anterior approach, whether it is appropriate or not, as I have discussed earlier, having seen various literatures, having various doctors deposed, even the family physician of the patient side also agreed that in such cases, in India, mostly the anterior approach is preferred. The court did not find anything wrong with the anterior approach. And also court held that even if the anterior approach, there are other ways of treating the patient, anterior approach being one of them and one of the recognized modalities of treatment. Just because the result was not as expected and has resulted in fatality, it can maximally be called as a misadventure and not a negligence by any stretch of imagination. Therefore, are the reactions of respondent tantamount to negligence? Obviously, the court decided that every possible care was given in this case. And the mere fact that despite going through the patient and the process diligently, the surgery was conducted, the patient was negligent, not only one time, but there had been repeated negligence on the part of the patient. He never reported for dressings and other things. And also the court observed one thing, which is very important for us from the point of view of our discussion, is that the patient never reported back to the hospital. There is no proximity of the injury and death. That is what the court observed, that the patient had gone to all over the country, had gone to Mulchand, gone to Ains, gone to Jodhpur, everywhere he has gone, but he did not fall back to Batra hospital. So therefore, had there been some concurrent infection somewhere, Batra hospital cannot be held liable. Also, patient was not getting the dressings done correctly, resulting into maybe a retrograde infection. Also that the hospital, the doctors have visited at his home several times, provided him transport and ambulance. So therefore, this part is more or less the family of the patient was quite a bit responsible in having this bad outcome of the patient resulting in death. And also the question came that if NCDRC erred in not acceding to the compensation, obviously the discussion clearly stated that the decision of NCDRC is unassailable. Therefore, the appeal was decided to be devoid of merit based on all this discussion that we had. It was stated that medical professions often called upon to adapt procedures. It was nobody's case that the procedures were not fraught with risks. Medical advances have given great benefits to the mankind. it was stated that it is very easy to have a post-event intelligence and blame the doctor for negligence. But no one can say that a surgery would not have associated risks. The great benefits to the mankind comes with reasonable risks. And also, like any other profession, doctors learn from their experience, and it was held that experience many a times teaches in a very harsh way. Therefore, it was stated that the negligence cannot be attributable to doctors so long he performed his duties with reasonable skill and competence. And nowhere it can be stated that the competence has to be always of the highest degree. And therefore, the judgment of NCDRC in dismissing the complaints were upheld, and no order to costs the individuals, that is the hospital and doctors, and the appellants, that is the patient side, were told to bear the own cost of litigation. Now the ratio, how the judgment was arrived at. As I stated earlier, that multiple reports clearly evidenced towards the tumor to be malignant. The only counterclaim of the appellant that the Tata hospital stated otherwise could not be verified by the appellants themselves. The literatures and various other books indicated that anterior approach is a preferred approach than posterior approach as claimed by the patients in dealing with malignance and not benign neoplasms. A judgment of Lord Denning in Rue and Woolley versus Pasteur Health Community was relied upon, which I just stated the ratio minutes before. And there had been no proof on record of any evidence that any sort of negligent action was done by the hospital could be found or could be produced by the patients. So taking these four issues into consideration, Supreme Court was pleased to dismiss the appeal. Now, what we take home from this case? One is duty to exercise a reasonable degree of care. Now, how a profession is different from an occupation? A profession is a type of work, is a nature of work in profession is such that it involves skill and specialities. And the work done is more mental rather than physical. When the commitment to ethics goes beyond minimally having a duty to moral correctness and transcends into greater benefit of the society, that is profession. A profession is thing when entry of a professional in its group is guided by other competent professionals and the standard is laid down through appropriate guidelines. That is a profession. And also a profession is a thing that gives you a better social status, which a normal occupation does not give. When all these fours are combined, a person is said to be professional. Therefore, the degree of reasonableness in his part has to be much greater, and mere lapse would be taken as a negligent behavior or negligent action. Therefore, through catena of judgments, a treating doctor or a hospital has basic four parameters on which their reasonableness would be evaluated. Like they should decide whether to undertake a particular case or not. Do they have facilities? Do they have specialists to deal with the matter? In deciding what would be the line of treatment, whether the line of treatment that is required, such line of treatment exists, such facilities, specialists, doctors, nursing staff, and other paramedics exist in the hospital or not. Then administering, how to administer that. And obviously, doing all this while remaining in the bounds of a consent act. The bounds of the consent would be broken only in case of extreme emergency, life-threatening emergency, and not otherwise. Next part is that what would be the consequence if there is any breach of such duty statements? The consequences may be threefold. One is deviation in practice amounting to dereliction. Is all deviations amounts to dereliction? Answer is no. In the present case, there had been a dispute whether anterior approach is better or a posterior approach would have been better. So such deviation are within the bounds of being correct. Then what is dereliction? In our first case, we have seen in Kunal Saha versus Sukumar Mukherjee case, in which extremely high dose of steroids were infused into the patient while treating toxic epidermal necrolysis, resulting in death of the patient. Such type of continued and prolonged and very high dose of steroids are definite deviation from practice, and therefore was taken as a dereliction to be. Now, resultant damage, which would have otherwise presumable and prevented. And how we understand that? Remember the case of Lakshman Balakrishna Joshi versus Dr. Trimbak Babu Godbole. What happened in this case? In this case, Dr. Godbole's son sustained an injury while playing cricket. He sustained a fractured femur. He had to traverse a long distance, and the manipulation was done without anesthesia, resulting in fat embolism and finally led into death of the young boy. So therefore, people are expected, doctors who are professing a particular way of dealing with treatment are but naturally expected to know what are the outcomes, what are the sequelae of a particular case. And therefore, since it is presumable and preventable, if it is not done, it can easily be stated that due diligence and care are not. A damage has to be direct and proximate result of such deviation. I would like to take the audience to a case in which Dr. Balamurganathan versus Mrs. Suganthi was adjudicated in Chennai High Court. In this case, the daughter of Mrs. Suganthi was coming back from school when a cycle which was ridden by a person on the wrong side bumped onto her. She fell down and sustained severe injury on the right lower limb below knee. There had been infection and tremendous pain. Mrs. Suganthi took the child to the local district hospital, and it was stated that the hospital would not operate or would not do any treatment to the patient unless they were paid 1,000 rupees. When 1,000 rupees was paid, the doctor merely gave anesthesia and put the child on a plaster cast. When the pain did not decrease and the child started having fever, she was taken to another hospital, and on opening this very heavy POP cast that was laid on her, it was found that there had been gangrenous changes in the leg and there had been a permanent ischemic contracture, resulting in permanent damage to the right leg of a young girl. So therefore, such damage is direct and proximate result of deviated practice, which is an acceptable practice. A deviation thereto resulting in damage obviously would be a breach of duty. Now the third point is the duty to undertake ethical practice. Please understand, though ethics and law are intertwined, they don't always go hand by hand or hand in hand rather. Outside one odd example, say a destitute patient, a pauper, you know he won't afford medicine the moment he leaves hospital. Request the nurse that those jabs that are given to him, the disposable needles in which an insulin jab given to him, be preserved for him. He would take them, wash them and reuse them later on. Acceding to such request, is it ethical? It may be legally all right, but it is unethical. Similarly, allowing a child to grow in womb of a mother born out of a rape, whether it is legal or ethical, which side the parameter should lie is a big question. Therefore, doctors do always face ethical issues when they are giving end of life care or giving an order for do not resuscitate. When it comes to the patient's confidentiality, the parameter of no malfeasance or misfeasance, only beneficence, patient's right to autonomy, as well as right to justice, upholding all this while maintaining an ethical as well as effective service, providing ethical leadership is very difficult, easier said, but very difficult to execute. Doctor, therefore, must have a clear understanding that what is negligence. I would urge that all doctors be very, very clear about Indian Medical Council. Now it's a commission. Their professional conducts, etiquette and ethics 2002 and 2009. So they don't go wrong in that. Of course, they must understand what is breach of legal duty, as I have discussed, how a criminal breach and a normal negligence would differ. What would be the liability on the hospital? Primary liability, vicarious liability, and also find out what are the pitfalls in their process. So all these may finally culminate into a situation where the doctors would be in a position where they can explain how a particular treatment modality has been done and how they had not been negligent. Above everything, it is very, very important that when there is a litigation, the defenses of the hospital and the doctors must be, I repeat, must be legally vetted, so that appropriately court may be made to appreciate about this case. So with this, I come to an end to this discussion. Should there be any question, I would glad to take.
Thank you, sir, for the very lucid and clear description of the case. Dr. Subramaniam here.
Yes, Dr.
Sir, I have around a few points, some of which are the lessons learned from this case and my comments and a couple of doubts.
Yeah.
So the first lesson which we all have learned from your lecture is given in the judgment itself under clause 30 for all surgeons, where, as you said, clearly document the failure of the patient to follow up as ordered by the doctor, and that can be taken as a contributory negligence.
Correct.
So we accept that, and we have started documenting this in our OPD notes also after every visit, and also in the discharge summary. In fact, we also give the dates and ask them that the consequences of that will be entirely on the patient if they don't obey that, and we are not liable to remind them of that appointment.
Absolutely, have it recorded always.
Yes, sir. Then the second point, which
in fact, Dr. Subramaniam, the court had mentioned it in their judgment that the frustrations of the doctors is quite apparent by seeing how patients had derelicted their directions, did not go by them.
Yeah. Second point I learned from your case is as given in the clause 31 of the judgment, where it was mentioned that a family doctor came and saw the records and also asked the relatives to consent for the surgery.
Yes.
So what we do now is, because that also this attempt for the doctor to get the message across, we mentioned clearly in the consent form that a doctor relative of the patient was also made to come and see the patient and give his learned opinion, so that later on when the case comes up for any legal hearing, it is very clear to the court that sufficient time and expertise was available to the patient to come to a decision for the given case. So yes, well accepted, and we take it a point and advise our doctors and myself to record this in the consent form. If any doctor in the family or relative agrees for gives opinion, so that is an added armament in our consent.
Yes.
Third point.
Here, Dr. Subramaniam, I would just try to say that, but then you or any hospital would not be bound by the opinion of a single doctor. They have every right not to get treated in your hospital or under you, but then that opinion is fair enough, but not no hospital is bound by that.
Right. It only says that the efforts were taken by the patient to cross-check and come to the conclusion.
Yes, 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 yes.
Third point, the damage to the pancreas, which was mentioned in this case, we surgeons must learn from this case that any such misadventure, it is always better to record and tell the relative, because later on that came to the defense of the respondents. Had they not mentioned it, it would have been very difficult for them to explain all the consequences. So a very transparent and prompt documentation of these complications is very essential on part of all us surgeons.
Correct, correct.
Yeah. Fourth point, also, as you mentioned, on 17th May, when the patient went to AIMS for the ERCP, so whenever a patient requests a second opinion, that we write it in the discharge summary that the patient is fit for discharge to another hospital for further treatment or opinions, and not fit for direct home discharge. So that line we always incorporate whenever they go from one hospital to other, so that very clearly we mentioned that that opportunity has been given to the patient to take other opinions.
What actually happened in this case was that he was very much in the hospital, and for ERCP he was taken to another hospital. It was not AIMS, another hospital. The question here was different. You see the dates, why I kept on mentioning the dates here is that he undergone ERCP, such an invasive thing, especially where the pancreas was injured, within 45 days of his first surgery. Generally, it is not taken up before 3 or 4 months after, of the surgery. So that is one where actually the court did not say much, but this was one of the weak points in this case.
Yes, yes. Then, as mentioned in clause 39 of the judgment, the patient had been under multiple treatments other than the main treating hospital during the course of the illness.
Yes.
So, and my question to you, sir, because for a patient-doctor relationship, every time a patient seeks opinion of many other specialists without the knowledge of the primary doctor, there itself automatically there is a breach in the patient-doctor relationship.
Yes.
So this part may be documented whenever they come for the later on, because that they have not informed us of these various consultations has to be documented, because that is actually a breach of the.
What I would suggest, sorry to interrupt you, I personally feel that the patient may not tell the doctor at all. That is one case. Doctor would be blindfolded. Second point is that it itself, like it is apparent on the face of record, if patient is saying so or showing that I have gone to 2 other doctors or 3 more hospitals that I have visited, if the patient is showing those documents, please preserve the document. So therefore, the proximity of a relation goes, and if there's a change of treatment modality, here it did not happen, there's no change of treatment modality, but otherwise if there's a change of treatment modality, your responsibility completely gets discharged.
There was also in this case where they had removed the word cancer from the discharge summary on the request of the wife of the patient. I really do not know why, but in today's circumstances, it may not be correct, because we should not change the diagnosis just because that word is not acceptable to the patient per se. So
no, but in this case, the patient insisted that it should be removed, or otherwise it will cause a lot of mental stress and agony of the patient to the patient.
Yeah, but I do not know the legal veracity of that, because
it really does not matter. It does not get down to that nitty-gritty, in the sense when the reports are sustaining that it's a neoplasm. You have all along treated the patient as neoplasm, and you could prove that this was removed at the insistence of the patient or relatives. Then it's fine. There's nothing wrong in that.
Yeah. The last comment are in doubt also. Lastly, I mentioned that I think the difference between causa causans and causa sine qua non, where is approximate.
Correct.
One last doubt: duty followed by a breach followed by resulting damage constitutes the essential ingredients of negligence. But what exactly do you mean, sir, by actionable negligence? How is it?
Okay. Right. Okay. I think I have got some time left, so I would just tell you a very nice story that would make the thing very clear. What has happened? There are 2 successive cases. In one case, I'll not take you to actually the law of tort and tell you those terminologies. That's not required. Just please understand that there has to be a legal right and there has to be a right which is actionable. In one case where it happened that a person wanted to cast a vote in favor of a candidate, the returning officer stopped him from casting the vote. However, the candidate for whom he wanted to cast the vote, he finally won, but still aggrieved that he was not allowed to use his right and franchise. That this gentleman filed a case and damages were awarded to him, and the returning officer had to pay the damages. That there had been a breach of legal right. Whereas in another case, there was one teacher was in contract with one school that in next 1 year he would not take up any job outside. It was a British grammar teaching school, in which what happened that within few months this teacher left the job and opened another school just in front of this previous school where he was employed, and was charging at least 1/4 the fees that the original school was charging. So many students shifted from the old school to his new school. As a result, the school in which the teacher was initially employed filed a case. Though they suffered damage, there was no legal right breach took place, and therefore no damage was awarded to the teacher. So here lies if there can be a damage, but does this damage or does this act or omission gives a legal right? Question is, the moment a patient comes to you, say I am a general practitioner, and a patient with a breast tumor comes to me, and there's no legal right per se if I refuse to see the patient or refer the patient to another doctor. There is no legal right that has been violated there. In a case in which you're treating an emergency case, there is no legal doctor-patient relationship. If you're examining a rape victim, there is no doctor-patient relationship. So no legal right accrues. When I say actionable claim, I mean that there has to be a breach to a legal right.
Okay, right. Thank you.
Any more question, please?
So thank you very much. I think it was a very lively session with lots of details and good points from Dr. Subramaniam as well. So thank you very much. Thank you, Colonel Ashish. We meet again after 2 weeks with another case, and also look at more nuances that needs to be learned on this. Thank you very much, and have a happy weekend to everyone. Thank you very much.
Thank you, sir.